Hello, everybody. Right now, this is Dr. Alex Vasquez coming to you live, and we are going to talk about the risks of nutrient toxicity using the antiviral nutrition protocol. I'm just going to show you some examples here. I think these are some of the more common examples. If I were your teacher and you were my student and I were asking you how to competently manage this program, these are the questions that you would find in your exam. So let's go through these. Skillful use of any therapeutic protocol requires proper patient selection, intervention, and customization, so we don't just throw the same protocol at everyone. And after we give them or prescribe the protocol, we have to manage it and monitor for efficacy or toxicity or whatever changes might occur in what we commonly call the clinical picture. So we manage patient status, any disease progression or maturation, because some diseases might look like disease A for the first month, and then later it starts to look more like disease B, and so maybe our diagnosis was wrong, or maybe we have another disease developing while we were treating the first disease. Iatrogenic toxicity is what I'm going to focus on in this presentation right now, especially when the toxic dose is also close to the therapeutic dose. That's a very important circumstance in which we really need to know what we're doing. So, sometimes with nutrition, generally speaking with nutrition, we have what's called a wide therapeutic window, which is the effective dose. Let's say down here, let's say the effective dose is whatever units it is, 100 units or 10 units or whatever. And let's say the toxic dose is 10,000 units of whatever, milligrams, micrograms, etc. But usually we have what's called, again here in pharmacology, a wide therapeutic window. We can treat them with an effective dose, and that's very far. We have a lot of distance between the effective dose and the toxic dose. With some nutrients, we don't have a wide window. We have a very narrow therapeutic window when the toxic dose is the therapeutic dose and the therapeutic dose is the toxic dose. So in those situations, we need to be at an expert level and be on our game, as the saying goes. If you're a clinician treating patients with this protocol or any protocol, then you have to be fluent with the potential toxicities and how to monitor for each of these. So this is true whether you're using nutrients, vitamins, minerals, amino acids, botanicals, and or drugs. If you're using all of those together, then you have to be fluent in all of those. You've got to know the drugs, you've got to know the minerals, the vitamins, the diet, your patient's status, especially in terms of liver and kidney function, etc. So these are the reasons why clinicians have to study and be very competent in each aspect of what they do. So we're going to look at these interventions. I've just selected a few, not really at random, but some representative examples of interventions that we might use. We need to look at these from a clinical standpoint in terms of their toxicity. The reason for that is because that's how patients present. They present clinically. They don't come in with laboratory results saying, hey, read these laboratory results to me. I think I've got a problem. They come in and they say, gosh, since last time I saw you, I feel better, or I feel the same, or I feel worse, or I feel different. And in some cases, what we're looking for is what is that different and what does it fit in terms of the patterns we have in our heads. When we undergo this process of pattern recognition, what can we match their symptoms to? And you'll see how that plays out here. So after we have suspicion of a potential toxicity, then of course we need to know how to test for it. And I'll show you how to do that in just a moment. So we're going to talk about a few select interventions here. We'll talk about the potential clinical presentations of toxicity. And we'll talk about how to analyze those from a laboratory perspective. So diving into this, let's start with vitamin D. What's the clinical presentation of vitamin D toxicity? So if you're using nutrition in your practice, you might reasonably be expected to know these things. Typical vitamin D toxicity presents with weakness, nausea, vomiting, and polyuria, which just means excessive urination. Usually that's secondary to the hypercalcemia, and that's how we test for vitamin D toxicity. So you can look at vitamin D levels, either 25 hydroxyvitamin D or 125 dihydroxyvitamin D. That's fine. You probably should, as a clinician, look at those periodically, at least at the initial evaluation, so you know kind of where your patient is in that spectrum. And then we follow up by looking at calcium levels if we are concerned about vitamin D toxicity. Obviously, if you're concerned about vitamin D toxicity, then you might reasonably look again at 25 hydroxyvitamin D, 125 dihydroxyvitamin D, because that clinical picture can change as well over time. If a disease was present that you didn't know about, like let's say the patient has tuberculosis or sarcoidosis and you didn't know it, and you put them on vitamin D and now their clinical picture is changing, through no fault of your own, you could have unmasked an underlying problem, and now your patient's got hypercalcemia and they come into your office feeling a little weak when you expect them to feel better. So this is within the range of things that we as clinicians have to deal with. I think that's a reasonably competent conversation, quick as it is, on vitamin D toxicity. Presentation, weakness, nausea, vomiting, polyuria. Other conditions present in the exact same way. That's why we take a clinical presentation and then we do labs if we don't know the answer. If a patient comes into your office with weakness, nausea, vomiting, and polyuria, that could easily be the same presentation, for example, as acute type 1 diabetes. Weakness, nausea, vomiting, polyuria, perfection. That's a classic presentation for type 1 diabetes. That's not necessarily a classic presentation for something like infectious diarrhea. So let's say your patient has infectious diarrhea, they present with weakness, nausea and vomiting due to electrolyte loss, for example, or dehydration, but they wouldn't present with polyuria if they're dehydrated. They would have oliguria or anuria. So that's how we as clinicians have to think about these things. Let's look at vitamin A. So with vitamin A, the therapeutic dose is very close to the toxic dose. So here's where we have to be on our game. So I typically teach this to students or to conference attendees. I teach them to think of this as 3 times 2 equals 6. That's an easy way to kind of establish some intellectual shelves upon which we're going to put this information. So we've got 3 areas. Each one contains 2 ideas or 2 books on your intellectual bookcase. So pain is headache and body pain. So I put body pain. Sometimes it could be abdominal pain, especially if they have liver toxicity. It could be right upper quadrant pain. But the reason I put body pain is sometimes it's described as bone pain, sometimes it's described as joint pain, so I just put body pain. Dry skin and hair loss. So dry skin means dry skin on their body, but also chapped lips. That's classic presentation, and also hair loss. So you've got 2 times 2 here. You've got 2 categories, each with 2 items. Headache and body pain, so that's the pain category. The skin category is dry skin and hair loss. And then we go to labs, and then we're going to look for elevated triglycerides and indication of hepatic congestion. So the toxicity of vitamin A is liver toxicity, manifesting as hepatic congestion. The labs that we use for monitoring or diagnosing what we think might be hepatic congestion, we use an assay for an enzyme called gamma glutamyltransferase and also total bilirubin. So if you see elevations in GGT or bilirubin, you might start thinking this could look like hepatic congestion. Oh yes, this patient's been on vitamin A for 3 months or 6 months, and maybe the dose is obviously too high for them, or maybe they have another liver disease and they couldn't tolerate a normal dose of vitamin A. So if a patient, for example, is alcoholic and they've hidden that from you and you put them on a reasonable dose of vitamin A, they could develop liver toxicity earlier than you expect, and maybe your assessment of the patient was correct, maybe your dose of vitamin A was correct, but they developed liver toxicity because they lied to you about their alcoholism. That's a possibility. And doesn't necessarily have to be that scenario. It doesn't have to be that they lied. Maybe they've got hepatitis C, they didn't know about it, or they've got hepatitis B, they didn't know about it, or they have hemochromatosis, one of the most common genetic disorders in the Caucasian population, and they didn't know about it. And now, because of the vitamin A, we have collectively unmasked a previously undiagnosed problem. Zinc. What is the expected toxicity of a reasonable dose of zinc, for example, as one might use in my antiviral nutrition protocol? The expected toxicity of zinc is nothing. Zinc is not toxic at the doses that I typically recommend. However, we could induce copper deficiency, and the presentation of copper deficiency, one of the earliest signs is neutropenia. So you order a lab test, or a lab panel in this case, called a CBC, or complete blood count with differential. And the differential is we're looking at different subsets of white blood cells. One of those subsets are called neutrophils. If a person becomes copper deficient, those neutrophils start to lower. That's a sign of copper deficiency, and we call that neutropenia. That's one of the earlier signs, not necessarily of zinc toxicity, but rather zinc-induced copper deficiency. From the doses that I typically recommend for zinc, let's say 30 to 50 milligrams, no one's going to get toxic from that, except under the most unusual circumstances.